it's going to remove the tumor. It's not stop the bleeding. You can make some bleeding. And you can see here, the tumor is quite bleeding if you use like microdebrider. So again, when you use Coblation, you can see how better you can see. You can see it's really clear here, no blood. So you can see if you go deep there, you can see the very dangerous or very important organ behind there better. And you can appreciate that how clear of the Coblation may help you. And this post-op after surgery, you can see we cut 2 years later, we cut the tumor out. So that what I want to share with you, that Coblation is really good to decrease the bleeding intraoperatively. So I can show you something else like this case. Patient, 76 years old woman, okay, with lung cancer, and it's not well controlled, and she have a lymph node bleeding, and she come to our department, and we do biopsy on the left node. We found it's malignant melanoma, and the PET scan showed this lung cancer, and we question that she have one more cancer, 2 cancer in the lung. One is lung cancer, one is metastasis of the malignant melanoma, and patient have visit. First, we don't want to do surgery, but she visit to ER 2 times because she have massive epistaxis. It's bleeding a lot. And you can see here from the scan, she have the tumor here. This is the tumor, this is bleeding. So the tumor is really, not too big. It's localized in the nose. So we had surgery to relieve the symptom for her. So you can see it here. The tumor is almost coming out from her nose. And this is malignant melanoma. So in this case, we know it's gonna have some bleeding. We remove the tumor first. Okay. And this how it looks like in the nose. So it's plenty of tumor in the nose cavity, but it's not invade the skull yet. But as we know that malignant melanoma is really aggressive, you can see I use the chroma system from star to magnify. We can see the dark spot here, so we can, as you can see here, it's dark here. So we suspect that it's maybe melanoma. So we can remove all the way from the front to the back of the nose. This is how we use the technology to help us, make us working better, like the Coblation. So now you can see this is a septum, this so-called scomocolumnar junction. We use Coblation to remove, and we expose to the septal cartilage. And here also the ethmoid lacrimal crest also, we can use Coblation to peel the tumor all out. And this, you can see it's really not bleeding a lot, it's dry. And we can see the vessel. This is the vessel in front of the first band, the olfactory nerve. And you can see here, this is the first band of the olfactory nerve. And that's we know the landmark now. And then we do the ethmoidectomy. And this frontal sinus is really clear, no tumor, just inflammation. And we can pull down. We know that the tumor localized in the nose cavity. So now we can pull down with the Coblation, and we use Coblation to, cut. And you can see that it's not bleeding a lot here. And we cut the tumor on block. Oh, sorry. I hit some button, sorry. Okay, and here, okay. And this, we remove the tumor. I'm gonna go fast forward. It's on block, okay. But we still have some tumor left over near the ala. So we can use Coblation also to remove the tumor and peel off. You can see some tissue here. And here, if you peel off, you can see this the nasolacrimal duct here, and the tumor is allowed here. So we want to cut it so we can preserve the nasolacrimal duct by cutting it. Don't cauterize it because it can make its obstruction, make a scar, and we can push the eye. So you can see the flow of the lacrimal. And we do the biopsy, all allowed to send for the first section. Also here, you can see this soft tissue beneath the ala, and you can see the fat beneath the skin. And then we do the bone for the better margin. We do the bone to thin the bone, allow to make sure that we have a good margin. And all the margin that we send, like a soft tissue all out, is free from the tumor. So we're happy with this case. And this is a final view. You can see this sphenoid here, maxillary sinus here, nasolacrimal duct. This is a septal collet. We cut it and we send for permanent to make sure that we don't have to left some tumor over. And this is a frontal sinus here. Okay, the next case, so you can see that how you can use Coblation like a to peel off the tumor all out the nose. And this the other case, 28 years old with left nose block. You can see the tumor here. And with the biopsy, it's located mucoepidermoid cancer, and it's something that not resist to the radiation and chemo. So the only choice that we can do is surgery. So we do plan to do nasopharynectomy. So first, what we need to do is remove the bone here, medial maxillectomy, remove the medial pterygoid, remove the lateral pterygoid plate and muscle, and then we do on-box dissection of the nasopharyngeal cancer. Okay, so as you can see here, this left side, this is a tumor all out here. This occlude the uterine tube. So that's why patients have the left ear block. So we do medial maxillectomy, and then we can looking for the SPA, sphenopalatine artery. And you can see here, this is SPA. Okay, and we control, we remove the bone. That's we remove the medial pterygoid, lateral pterygoid by using the drill, and we control the vessel. And as you can see now, all the medial pterygoid bed is gone, and this medial pterygoid muscle, and this is a tumor, and this is a cartilage. So now I prefer to use all 100% of my case. Maybe I do nasopharyngeectomy. I can use a Coblation because it's remove the cartilage very well, better than the monopolar cautery. And you can see this levator veli paradigm here, and we peel this is a tensor veli paradigm, levator veli paradigm, and this is carotid. Oh no, this is a uterine tube, okay, and this is a tumor, and you can see pivotal fascia, and you can appreciate that how the Coblation make our life easier. It make our surgery faster. You can see that I do with only myself. I use two hands. I don't need someone to help me to to suction around. If I use cauterization, I need someone to suck the air, suck the foam. And we remove the tumor through the mouth here. And then we send for the first section from the nose. I do biopsy all out the surgical area to make sure that all out is free of tumor. But the report coming out that here they have some tumor left over and all out there. So now I will remove, you can see that we can use Coblation through the mouth also to remove the lower margin. Because I do fasting and the lower margin some still positive, I cut down more and send fasting again to make sure that we don't leftovers. Now you can see I take out the levator tensor and levator levi palatine out already, and it's come back, it's free of the tumor, its margin is free. So it's good news, and we stop the surgery. And you can see here how good healing after we use Coblation. I used to use a monopolar cautery before and leave a lot of scar because of the heat, but the Coblation is make the healing faster. It's much better and no crusting. Okay, so this is the next case. I have like 28 years old male with meningioma. WHO grade 3 is really bad prognosis. We also know it's anaplastic meningioma. And you take a look here. So when about 5 years before I do surgery, I did surgery in this case 5 years ago. She had meningioma in her head here. It's a big one. The neurosurgeon do craniotomy and remove the tumor. This is a post-op. 5 years later, the tumor in the brain is not big, but you can see the tumor is run down to the nose here. And it's involved the temporalis muscle. This is temporalis muscle. It's involved temporalis muscle, and this is artificial skull. So her vision still okay, not really bad. She don't want to remove, and you can see the tumor don't want to remove her eye, and you can see the tumor is inside the cornea sinus here. So our goal is just to relieve her symptom because the prognosis is really bad already. So I do medial maxillectomy here. Okay, and then I do the Denker procedure to go laterally. We need to go bilateral to, okay, you can see I remove the posterior wall of the maxillary sinus. And then we take out the bone of the posterior wall of the maxillary sinus, and I use microbial first, and it's bleeding a lot. You can see it's bleeding, and you can see now when you use a Coblation, how good is it? It's no bleed. It's really feel blood. You can have a better view, but you can see the movement of the muscle because the Coblation can stimulate the nerve, can make the muscle move. You can make the muscle twitch. Okay, and as we know, sometimes the meningioma can have the bone inside. It have the bony content inside. So this thing I can use a dual because the Coblation cannot remove the bone. The dual will be better tool to remove the bone. Okay, that's some limit. And the Coblation can be clogged with if you have the bone pitch there. It can obstruct the wound. And here, this we expose the tumor. This is a meningioma. It's very sticky tumor, and it's not. I use microincubator. It cannot remove really well. So Coblation is better in this case. And as you can see, this temporary muscle, the tumor, the meningioma is bending in temporary muscle here. And let's remove the tumor. And we can see this the dula. I will not go inside because we know the tumor is still in there, but it's not help anything if it move more. It can injury to the carotid and cornea sinus. And this below, and it is beneath the eyeball. So I try to remove the tumor as much as possible. I use a suction cullet here to remove it from the eye, and I push the eye, and then you can see it tries to escape it from the eye, and allow to make clear. And I do decompress the optic nerve in this case to make sure that she's gonna have better to secure her visual. And this is a post-op. You can see we remove a lot of tumor with endoscopy. We left over here some part here, but really small piece of that close to the cornea center. We just leave her symptom, make her have a better quality of life. Okay. What about the dura intracranial part? Okay. So normally when you remove the dura, you need to do the cold cut. You use a knife and go faster. Okay, you can use the knife and open the dura. Okay. So normally our technique, we use a lot of surgeon, we use cottonoid, to put it between the dura and the brain, parenchymal, between the dura and the brain tissue, and we use a cold knife to cut it. Okay, use a scissor, whatever, to cut the dura to make sure we don't make a heat, to injure the brain inside. And we use a cold knife all the way down to remove the dura. This is how we done, like a classic technique. Okay, how to remove the dura with the sharp cut with the cold knife. And you can see here, this is a classical technique that we do, and then we start the bleeding all out the edge of that we cut, and you can see here. And you can see here is no injury to the parenchymal here when you use a cold knife. And what about if we use Coblation? We have, Dr. Richard Howie, my friend Dr. Snit Wong Konkiat, he did research that they compare in the cadaver. They compare the damage. If they compare with the Coblation and CO2 laser, you can see that with the Coblation, it's no heat, no damage inside the dura. But with the CO2 laser, it's a lot of heat. We know that, and maybe monopolar coatry also. It can have a lot of heat, and it can injury to the dura, and it can injury to the brain tissue. So Coblation is reduce the thermal mucosal injury, and it's less bleeding, and it's very safe. So I can show you how to use it. Okay, this case, there's a tumor. Okay, we try to remove the tumor, and we expose to the dura, and the tumor already invaded to the brain. Okay, it's epithelial so we need to remove the dura, and you can see I use Coblation, and now we can expose to the dura. And if you see the bleeding like this, don't use the Coblation. I recommend you use a bipolar to stop the bleeding, with the vessel bleeding. And then as the same, I put the cottonoid, and between the dura and the brain tissue, and we use Coblation. Coblation is also very safe. This technique is very safe. You can see that when I use it, I use Coblation at the dura, but the heat can be absorbed by the cottonoid. You can see here, cottonoid will absorb the heat, and also it's linked with the slide. So it's no heat, and you can see no heat damage to the brain parenchymal here. It's really safe. So I'm going to show you one of my cases that we use Coblation to remove the tumor inside the brain. This is a 62-year-old adenocytic carcinoma, and you can see here, some doctors have to face because they don't realize it's cancer. And you can see the tumor is inside the orbit, and it's go inside the brain here. And you can see the bleeding. This is a bleeding, and this is a tumor into the frontal lobe here. You can see here. So the tumor have 2 points. It's invaded into the orbit and is invade into the frontal sinus. I do surgery in 2013. And let's see how is it. So this all of this is tumor. Up there, this is axillary, this is olfactory cave. So first, I looking for the orbit. Okay, as my landmark, I gonna free the orbit, looking for the lamina papillacea, and you follow to the back, we're gonna hit to the skull base. So here the lamina papillacea, and then remove the tumor, and we can know that the dura behind there. I go fast forward a little bit, okay? And you can see this is a frontal lobe here. And this is a tumor all around, and we can see it's stuck. Okay, the dura is already invaded by the tumor, and this is the orbit. The tumor is really not losing. It's not suckable. It's not suckable. We try to suck it. It's moved together with the brain parenchyma. So okay, now we remove the bone that was involved by the tumor, and this is the optic nerve here. So we're gonna feed the tumor from the optic nerve. I normally use a suction or with the QLED, run QLED, to peel off the tumor from the optic nerve. And you can see it's possible to kill it. It's from the optic nerve here. This is the optic nerve, and this is the dura. This is a tumor inside the brain. And now I remove more skull base, and we can see the tumor. That's the dura. So normally this kind of tumor, you need to internal debulking to make it fall off, and then we remove it. And I can compare to you. I use micro divider. I use bipolar. Bipolar is really difficult. I don't have really good angle here to remove the tumor. So after that, I use Coblation, and you can see how better you have the view. And you can see here, it's really good view now. It's dry. It's not breathing. I can see the old blood over there. I can start to see the normal brain tissue. And yes, you can see that they have blood accumulated inside the old breathing. And now when we can internal debulking, now we can peel off the capsule of tumor. So we can use the classical technique. We can use a cold knife. We're gonna suck the brain and suck the tumor out. We can use the sharp knife. Okay, now you can see now we can leach the normal brain tissue, and we remove the brain tumor. We remove the cancer that is involved into the brain. Here, okay. And then this is orbit. We cut the tumor out from inside the orbit. Okay. And we send for the first section all out here to make sure that we don't leave some tumor behind. And you can see the frontal lobe is falling back because we remove the tumor inside. And let's see how the post-op. I mentioned to you, I do surgery in 2013, and this is 2017. You can see it's free of tumor. Also 2020, he still come back every 6 months, and he's still free of tumor, except he have meningioma over here because of something radiation. Okay, that's all my presentation. Thank you. And if you can leave the question in question box, we're going to talk about that later. Okay.
Beautiful presentation, Dr. Bonsam.
Thank you. So I think we're going to have some poll before the professor work going to start this topic.
I'll just launch the poll. Request the attendees to kindly submit your answers.